Good morning. Good to be with you all this morning. And I suppose one of the things I'm always really struck by when I get the opportunity to be a guest in the lives of so many people is the great benefit to starting a morning as Elder Tom has done for us, reminding us that we sit or stand, as the case may be, but we are on sacred ground. So it's a blessing to be a guest in your conversation. And I think at best, that's really the essence of what I'd like to speak about this morning. How we can find ways to be better guests in the lives of the people that we serve. Because I think that's what it's all about, isn't it? We can talk about services and programs and all sorts of legislation. But if we can't assume the kind of posture that we've already seen modeled this morning, then I think it doesn't really much matter what our theories are or our models are. So I hope that I can be of service this morning in sharing some thoughts about what the world would look like if it were more community-centered and if we were more interdependent in all senses of that term. So it feels like a great opportunity, and I think some of us are together a little later on to drill somewhat deeper into that. But over the next 40 minutes or so, what I'd like to do is I'd like to consider this idea that our neighborhoods, our small bounded places like our villages, are themselves health creating. Just to give grounding to what I mean by that, I'd like to start with a story. A couple of years back in Shreveport, Louisiana, in a high school, over a period of about 3 days, 23 young students, young boys, were arrested or suspended or indeed expelled from that local school, all related to physical violence and the spilling over of serious conflict. In response to that, and again, picture the scene, it's important to have some context here. In response to that, many of the professionals in the lives of these young people began to ask serious questions about, what has gone wrong in terms of my principalship? What's gone wrong in terms of my counseling? Was the staff nurse present enough? Were the security guards? We have this awful situation in so many schools around the world now, particularly the US, where kids are going in to what is a culture of prison rather than a culture of education. Our schools really have become fortresses, right? But they were asking those questions and reflecting on their own professional practice. And at the exact same moment as that reflection was taking place, 40 dads got together and they called themselves Dads on Duty. These were local elders, if you want to think of it in those terms, local dads or indeed men who wanted to stand shoulder to shoulder with their sons and with the sons of their neighbors and say, you know what, maybe we don't have a youth problem. Maybe we don't even have an education problem. Maybe what we're seeing here is a village problem. And it's not going to be responded to by having better principals or better security guards or better response time from police. It's going to be responded to when vigilant elders, not vigilantes, when vigilant elders show up. And there's empirical evidence that they were right. So most of them worked or volunteered. They were busy people. But they put a roster together, and each day they would come in 4 or 5 of them. And using high fives and bad dad jokes, they loved those children back to peace. Because they understood something that's at the very heart of what it means to be well and to grow well in a community. It really does take a village. But that asks the question then, if it takes a village to raise a child, what does it take to raise a village? And I suspect we've taken our eye off that ball big time. And it's coming home to roost. We had a glimpse in COVID. I think we're forgetting what we've learned. Back in 1972, Christopher D. Stone, an academic legal mind, wrote a very important, groundbreaking paper which asked the question, should trees have standing? So this is a question that he was asking, not just about trees, oceans, and natural parks, and so on and so forth, 1972. And it was a wild idea for the time. Basically, he was arguing that our natural world, Mother Earth, should have a legal standing, just the same way as I do as an individual. And it's not so wild an idea today, because it's 2023, and to a certain extent at least, some people are really catching on to this idea. For example, the government of New Zealand in 2016 and 17 relinquished ownership over a national park and gave it its own legal standing, recognizing in law that it is an entity, it is a being, it is our relation. I want to suggest today that we need to extend that thinking to our neighborhoods and to begin to think about our neighborhoods as the primary unit of health. Not individuals, particularly not sick individuals or isolated individuals or whatever pathological label we want to associate with individuals, because we're never any just one of those things. And not our institutions. So much of the policy, I think, that we currently are working within talks a lot about behavior change, changing the lifestyle decisions and behaviors, behavioral economics, and so forth. So it's really about getting individuals that we think should know better to be better, right? They'll be better if they listen to us because we know best. So that kind of expert narrative. I'm not against experts, by the way, but I am against top-down do-goodery, because it rarely works. But also, I think what we have now is we have a challenge, because if we're not talking about behavior change, we're often talking about institutional reform, as though we could somehow suck salvation from our own institutional thumbs. And I think we all pretty much know the game is up on that one. It's not going to work. Now, that doesn't mean that individual behavior change doesn't matter, and nor does it mean that institutional reform isn't important. It just simply means, in the principle of Buddhism and Buddhist economics, that there's a third way, a middle way, that actually opens up the prospect of bringing every individual and the gifts of every individual into this conversation, but also enabling our systems to be of better service, to be better guests in the lives of the people that we serve and their communities. Sometimes it feels to me, I work in about 38 countries around the world, so I have the privilege of working with people in policy, and I have the utmost regard for people in a policy context. I think it really matters. But I think one of their biggest challenges is the lack of proximity to the everyday lives of the people that they're trying to support. So it's as if they know everything in general, but they're trying to have conversations with people who care about things in the particular. And it's like ships passing in the night. Almost as if, I've just come over yesterday on a nighttime flight. And as you look down from the airplane and you're flying over a province, you can be forgiven for thinking that, the power source that's down there are the institutions with their lights on, the factories, the schools, the hospitals. So if a neighbor sitting beside you on your nighttime flight says, hey, where's the power down there in British Columbia? You can say, well, there's a hospital, and there's a board of management meeting there, and so forth. But you're also probably likely to see a lot of dark matter. And sadly, it seems to me that our neighborhoods, our villages, our small bounded places, our communities have become that dark matter. We've begun to see our communities as passive recipients, powerless recipients of our services. And what I'd like to argue today, if these communities have standing, is that we need to change our narrative in the way we get alongside them and begin to start seeing them not as passive recipients of our services, but really changing the narrative to talk about them as citizens and as creators, not just co-creators, but as creators of health and well-being in their own right. So that's by way of setting the scene. That's what I'd like to try and talk into over the next few minutes. So let me get my clicker. One of the challenges, I think, in moving to a narrative where we could really emphasize the health-creating capacity of our small bounded places is I don't think that's a very common idea. I think what is probably more common in our narratives around the world these days, particularly in an industrialized context, is that our health is in the hands of our doctors, that our safety is in the response time of our police officers, that our children's education is in the qualifications of the teachers that teach them. And I think that's rather compelling, actually, because there's some element of truth in all of that. Our professions are hugely important. So this isn't me saying anything to down our professions, but my goodness, what a crushing burden to place on our professions. That all of our health, all of our wisdom, all of our justice is going to somehow be outsourced and put on the shoulders of a qualified person, a salaried stranger, not a near neighbor. I think we need both. And in a sense, I think the challenge for health and social care in the integrated sense as we go forward in every province and in every household is to work out what it actually means to think about ourselves as creators. That starts by recognizing that the glass is actually half full. That in all kinds of ways, in our small bounded places, in our communities, and in our neighborhoods, there are health-creating capacities. But mostly because of modern life and modern narratives, we cannot see or hear them. We tend to put them down. I have a friend who jokes, that every needs analysis needs analysis. Because I don't know if you've noticed, but every single time we go and we extend a handshake with our communities, we're not blessing them, we're analyzing them. We do, the first thing, we do a needs analysis. Tell us everything that's broken, pathological, not working, and that needs fixing. And then we come up with services and programs to respond to that from outside in and top down. Some of the more progressive among us get alongside people and do that in a co-design and co-productive way, but it's still about services. So the whole narrative is still about the institutional domain. And what I want to suggest is there is another way that actually enables us to provide really good quality services, but in a way that supplements the capacity of the community rather than displacing it. And that other way, if you like, that middle way, is to start by recognizing what's strong within communities, not what's wrong. And I think that starts by, instead of doing a needs analysis, starting with an asset inventory. Because after all, how can we possibly know what our communities need until we know what they have? There's another reason, and many of them actually, why I think it is so critical that we move into thinking this way, moving into the glass half full approach. And I want to share 5 particularly powerful and compelling arguments for moving in what I would call an asset-based community development direction as opposed to a deficit-based way of thinking. The first is, it's really, really dangerous and harmful and iatrogenic to think that our communities are broken and therefore need fixing. In all kinds of ways, we will prove that narrative true, but the actual deficit that creates in terms of social capital is unconscionable. Communities and individuals and citizens are not people that are broken and need to be fixed. And that's the first point. We need a better narrative. I honestly believe, I've heard somebody recently use the term youth at risk. I've absolutely every conviction of any young person I've ever met that they're not at risk, they're at promise. They're only at risk of adults who can't actually see their promise and recognize they're leaders of today, not just tomorrow, and support them. Not just to organize them with other young people in a youth program, but to send them the clear message that we need them. Most of the young people I'm around don't need us to treat them like they're needy. They need us to need them, to recognize that they have contributions, that they have gifts. Communities are still exactly the same as our young people. In fact, across the life course, we need to shift the narrative from needy to needed. Finding ways that we enable every single individual in our communities to contribute their gifts because we cannot do health without them. and all means all. The other reason I want to suggest that we would move in an asset-based community development direction is because, certainly in most of the OECD countries that I work in, 2/3 of all of the money intended to end poverty is not going into the pockets of people who are living with the consequences of poverty. It's going into the pockets of people who are paid to provide services to those who are living in poverty. Don't get me wrong, in many cases that's really good value for money. But isn't it really striking that when you get down on the ground and you ask people who are living with economic poverty, because remember, economic poverty is just one of many ways of experiencing poverty. But when you ask them, hey, Cormac, if you had the salary of the people who are helping you, would you use that money to buy the services that they're currently providing you? What do you think people say? No. So there's the feedback. You save millions on evaluations. There's your answer. The jury's in. The other challenge, though, is that at the collective level, if people feel that they don't have a sense of agency, that they don't have a sense that they are producers as well as consumers, that they are citizens as well as people who will sometimes use a service, then what we'll begin to see is that active citizenship will retreat. And I think we are seeing that. So many people are much more likely to be watching an episode of the American sitcom Neighbors than they are to be making friends with their neighbors and organizing to co-create health. But I think that's exactly what we saw happen during COVID in many, many places. People started realizing that they had health-creating functions. As first responders in the front line called their neighborhood or their community, they had the freedom, for the first time in a long time, to, number one, recognize the institutional world had hit the limits of its own capacity, and if they didn't step up, things would not work out very well. So active citizenship is an absolutely quintessentially important part of health and well-being, properly understood. And I think everybody here appreciates that when we talk about health, we're not talking about medicine. We're talking about social and political change. So the fourth reason I want to share with you is that, and this really bothers me and worries me because I see it so often. I think when we go in to neighborhoods and bounded places and we define them by the sum of their pathology, we talk about super areas or highly disadvantaged areas. We actually pit communities against each other and say, no, you're not messed up enough to warrant the funding. Sorry, maybe next year you'll be more messed up and you can apply and you'll be successful. So we're literally saying to people that it's only when you're on your knees, more on your knees than your neighbor, that we will actually help you. That does two things. One, it waits too long and gets there too late. But the second is it actually pits people against each other. It's the opposite of building community. There's a third worry I have around this. I think people have begun to internalize that map of their neighborhoods and their communities, particularly young people. And we'll see this regularly when kids will apply for jobs, for example, but won't put the name of their neighborhood, their address down. What they're saying to us is they've internalized something about the story of the place they called home, which is Unheimlichkeit, the German word is, unhomely, uncanny. It's a place of alienation. It's not a place where I can grow well or someday hope that I can actually prosper and have children myself if that's my journey. That, to me, is the opposite of health and well-being. And the fifth reason I think we really need to move in an asset-based direction and really entertain this idea that our neighborhoods are places of standing, particularly when it comes to health and social care, is because so many people are organizing, even in the name of community, around single-track politics. I often think our neighborhoods are almost like a tangerine, where we've broken them segment by segment. We've got the youth at risk, the frail elderly, the ex-prisoners. By the way, why do we call people who are leaving prison, trying to come back to community, ex-prisoners? Why don't we call community returners? Because I think we prefer to see the deficit than the possibility. It's a single-track politics. And in the politics of our narrative, which is so much about economics of scarcity, particularly around health, where we're much more interested in the arguments about hospital beds than we are about hospitable communities, single-track politics plays really well, but not for our communities. So if we're looking to do something that's going to radically move us in a more democratic direction, I think we have to figure out how we can radically enable people to participate in everyday politics, not just party politics or single-track politics. And some of that means we need to get beyond our silos, our single issues. I often joke that silos are where smart people go to do dumb things. Elder Tom reminds us, all our relations, we are interdependent. This narrative of promoting independence, I think we need to move beyond. You can't be independent unless you're interdependent. One of your great leaders, I think, in the disability movement, Alet Mansky, wrote a book recently about this, where he talked about the importance of understanding that people want a life, not just a service. It's interesting, though, you know, when you ask the question, so if the truth of the matter is, we all agree here, I think, that the social and political determinants of health have to receive the lion's share of the focus, because 80 to 85% of what determines health and well-being is related not to medicine, but to social and political matters. Well, the interesting question then we should ask ourselves is, how does that work out on the balance sheet? If that's the case, how much money are we actually spending in community development, in enabling our communities to be connected, to be powerful, to be vibrant, to be health-creating? And the answer is pretty disturbing. Right across the OECD country, reputedly, I don't know if this is apocryphal, but reputedly, President Joe Biden, in the early stages of his office, was to have met a number of very senior policymakers around health, and they were talking a lot about value-centered healthcare. And he reputedly, I can't swear to this happening, but it's such a great story, I hope it did. He reputedly said, "Don't tell me what your values are, show me what your budget is, and I'll tell you what your values are." So if we're spending 88% of our budgets on what actually at most, at top tilt, will create 15% of the outcomes, my goodness, what's going on? And actually what's going on is politics of scarcity, and we're talking out of both sides of our mouth. So this is a challenge to policymakers. It's also a challenge to leaders, particularly political leaders. Much of the change that's required is a change that is going to be about taking money that is locked into the acute ends of our system and moving them up. It's not that we don't ideologically know this needs to happen. It's just we have to have the very tough political arguments that actually enable this to happen. And hopefully we can have those before another major crisis. Because the evidence is really clear on this. The evidence is powerful and it is compelling. These are just factoids, they're moments in time, but it's striking to, for example, recognize that according to the ONS labor market trend survey, that people are 4 times more likely to find a sustainable livelihood if they're at the center of a connected community. It doesn't mean that services like a job center aren't important, but they cannot do it on their own. It's also really striking to look at safe communities and what it means to live in a safe neighborhood. Robert Sampson, the preeminent social scientist in terms of that question, is very clear on saying that there are 2 key determinants of public safety, and they have nothing to do with the number of police or the response time. The first is, how many neighbors do you know by first name? And the second is, how often do you do things together? Are you willing to get involved in the commons, in the shared community life of your neighborhood, of your place? Those 2 things determine safety much more so than any formal or enforcement intervention. And what's really striking is I don't think that public narrative is well known. So part of our challenge is to shape that public narrative. And if necessary, to contest the old story, because the old story is not going to play very well in the next 5 to 10 years in a pandemic-conscious future. So if we're going to flourish forward fairly, I think we're in a particularly unique position to illustrate that courageous leadership, because it's not technically hard to make these arguments. It's morally, perhaps, hard to stand them up in a world that's saying something very different. But health, I think, is uniquely placed to provide that leadership, because, again, the evidence is so clearly telling us that people are 27% more likely to be healthy in connected communities, in places where they have discovered connected and are mobilizing their assets, their building blocks and resources for a good. There's lots of examples, but one that strikes me as worth sharing in this context is from the village of Frome in the UK, where over the course of 3 years, by just connecting people at the local level, they were able to reduce emergency hospital admissions by 17%. Now, don't get me wrong, that wasn't the reason they did it, okay? I'm not in the business or interested in trying to save the system money. I'm interested in saving people from the system. Because if people aren't interdependent in natural life, they're institutionalized. It's really, really striking how often in social care and health care we talk about surrounding people with services and programs as good outcomes, rather than surrounding them with natural life and beauty in a sense that they're in reciprocal relationships. They're in groups that they're missed on the days that they don't show up. Brigham University tells us that if I'm not a member of a club or a group and I join one, I reduce my chances of dying next year by 50%. There's no medicine that's better for your health than community. So one of the challenges, I think, is that this is very slow work. And our policymakers, particularly in the face of crisis, love things that they can scale. You know, they'll find a nice boutique idea and they'll say, oh, that's wonderful, let's try and do that for everybody. So yeah, that's where social prescribing comes from. And what I'm talking about is so much more radical than social prescribing. I don't want to knock it, it's a step in the right direction. But boy, are we going to really expose all those good people who are out there trying to do the link work if all we say to them is, you know, be air traffic controllers and kind of point people in the direction of various projects. But we don't remember and we don't understand that community doesn't just happen. You've got to build it up from the grassroots, and that happens at the speed of trust. So let's talk about the speed of trust. One of the questions I have is, does trust have a number? Robin Dunbar, the social scientist, says yes, it's about 150. Okay, that's been contested of late. So there's an argument somewhere between 69 and 268. But hey, who's counting, right? The point is, it's small, right? It's small. 50 years ago this year, E.F. Schumacher wrote a groundbreaking book called Small is Beautiful: Economics as if People Matter. Radical idea, right? He's ahead of today, let alone 50 years ago. And it's a wonderfully important book because he says we cannot talk about health separate from land, separate from Mother Earth, separate from social care. And part of the challenge is, in a world that tends to silo and break everything apart and turn everything into programs, that is exactly what we do. In 2013, in a Chinese restaurant in Evanston, I had the pleasure of sitting across from Marion Thompson, one of 7 founders of La Leche League International. And that started in 1953 in a small neighborhood in Chicago, against the backdrop of physicians and people who should have known better arguing that formula milk was actually superior to breast milk. That's why when people say to me, you know, I only do things that are evidence-based, I ask them, who bought the evidence? Sounds a bit cynical, but you do have to trace the money. I'm much more interested in practice-based evidence, right? And much of what I'm talking about hasn't been practiced and therefore doesn't have the evidence. So if your policymakers say they won't fund it, it's end game. But that's where the courage comes in. So I asked Marion, you know, you've been around the block 60 years now. And it's a movement, look, I know different people have different views about breastfeeding movement. I don't want to get into that. But it's a movement that hasn't been appropriated by the system in the institutional sense. What can you share that you've learned? And she said, I can share 3 things. I'll just share these very briefly. The first, she said, is we learned that if you're going to be serious about being community-centered and being a social movement as opposed to an institutional reform agenda, then you've got to keep everything mother-sized. It's got to be local. It's got to be in pram pushing distance. Keep everything mother-sized. The second thing she said was, we recognized there was a lot to be angry about, and legitimately so. But we also understood that if you were going to create a social movement that was broad and engaged as many people as possible, then you really needed to be clear about where you were going, what you were for. And it needed to be bigger than just breastfeeding. So we were for community. Margaret Wheatley says, whatever your question, community is the answer. Right? The third thing she said, by the 1980s, suddenly, she kind of said this with a wry grin, she said, breast was back in. You know, breast was best. Right? So breastfeeding and nursing was suddenly popular again, to such an extent that they were finding in their living rooms where they were meeting as mums, as nursing mums, that they were having people from the professions come in, just in case. You never know what a breastfeeding mum could say to another breastfeeding mum, you know. So, and I said, well, what did you learn during that period? And she said, I learned something about social movements. When the movement was just word of mouth and we were meeting in our living rooms and we were kind of, you know, supporting each other, it was all member-led. We did the work. We defined the issues. We defined the solutions. We were the primary actors. But as the professions started to realize the importance of breastfeeding and they started to move into our living rooms, many of our neighbors started moving out. They stopped showing up, largely because they felt, hey, if I want to see somebody like that, I'll go to the clinic. They're looking for something in the living room that isn't in the clinic. There's a different operating system going on there. And what she found, until they actually did something about that, and this is their third insight, was that they needed a border hound. They needed somebody in the middle of the institutional overreach that they were experiencing and the fragile growth of social movements among their neighbors. And that came in the guise of Professor Robert Mendelsohn, who was a great believer in saying to the institutional world, back up and give the community space. Your job is to be medical authenticators of the non-medical. It's to cheer people on, lift people up, not to engage them. What I'm talking about here is even more radical than community engagement. It's about community building. We can't, in fact, engage with communities if we haven't done the work to enable them to become communities in the first place. And that starts with the principle of first, do no harm. Right? We've got to give them space. So it isn't about doing change to people, for people, or even with people, but it's about making sure we don't do for people what they can do together. It is a misuse of our power to solve problems that don't belong to us. So if you're looking around the province and you're seeing breastfeeding groups that are being facilitated by paid practitioners and wouldn't meet but that they were there, then that's a question about community development practice. It's not a reflection on people's apathy or people's care about their health, but we have overreached. We've literally moved into space that doesn't belong to us. In a sense, what I'm touching on here is power, and I'm trying to illustrate, as I think Marion Thompson was in her 3 insights, illustrating that the dynamic between the institutional world and the community world, and you see, I'm using a hydraulic relationship to try to illustrate it here, that over the course of about 100 years, functions that belonged to the circle, to the community, have literally been outsourced over into the institutional world. So I'm not knocking the institutions for this. There's kind of a dynamic going on. And as people became more and more defined as clients and as consumers, and the professional world became more and more elevated into the role of the people who have a monopoly when it comes to health, what did we start to do to our professions? we started to burn them out. And at exactly at the same moment, we stopped trusting them. So the very moment we elevate them to the greatest pinnacle of responsibility, we actually don't trust them. And at the exact same moment, our social capital is so depleted, we can't even imagine a community alternative. And that's pretty depressing. So I should lift the mood. There's a lot to be hopeful for. And as I look across the various countries that I'm working in, I am immensely hopeful and immensely excited by what I'm seeing. Because what I'm recognizing is that so many people just like you, initiatives like Hey Neighbor, initiatives where we're seeing health folks really getting alongside communities, and you're in this room. What you are doing is you're relocating authority back into civic space. Instead of being the syringe that pulls the community health-creating capacities out of our communities, you are saying, no, I authenticate your capacity. I'll support you to get organized. I'm not going to do for you, you can do for yourself, but I will create the conditions within which you can flourish. So in a sense, you are, and it's a bit of a crude metaphor, you're the hydraulic jack that lifts the car up. You're not just putting people in the driving seat, but we've actually got to lift people up. We will never, ever do anything worthwhile with communities by putting them down. And we cannot lift communities up by putting them down. That's what an awful lot of our needs analysis do. Most people, because it's written in Greek, don't even know what we're saying about them. But those that do are saying, what they're saying is, here's what we're missing, what's broken, what we don't have. But aren't we lucky that we're getting the services? Or what's probably more likely happening now is we all know how broken we are within these narratives, but we're more frustrated than ever because the services aren't coming. And that's the message. The cavalry isn't coming, folks, so the responsibility is on you. All the responsibility, but none of the agency and none of the money. Of course people don't trust us. But you're the people, I think, who can disrupt that and create good trouble. It's an interesting question, isn't it? Instead of saying, how do I reform my institution? Asking, what's the community alternative to the standard program or institutional intervention? And how can I launder, is that a word that I'm allowed to use? Some of the resource out of the acute end of things and move it upstream. We all know the adage, the metaphor of the ambulance at the bottom of the cliff. And we have, I think, over the last 30, 40 years, we have been in a cycle of arguing for building the things at the edge. 2 cheers, not 3. I reserve the 3rd cheer for those that are doing the work well in from the edge of the cliff, who are not just building the fence, but are recognizing that it is only by building our communities that we can actually begin to create health, not just prevent illness, or indeed be quicker at our interventions at the bottom of the cliff. So this narrative, I think, is important because, in essence, what I'm saying is there are 2 tools for social change, including health, broadly understood. The first tool is definitely institutions, although I don't think in hierarchical terms it is the first. And the second is community. So I don't want to make this an either-or. It's a both-and. But I think what we have to understand is these tools are different operating systems. Our institutions are not a proxy for community. They cannot do what community does. Our institutions are really important for ensuring quality control. It's really nice to know if I'm going in for a heart procedure that I'm not going to get one that's of a different standard to another person. So quality control matters. Institutions also are places where goods and services and programs that are needed are actually provided in a way that's equitable, in a way that's accountable. Again, really important. But what institutions largely do is they have relationships with clients and consumers. Institutions are not your friend. Institutions are not your neighbor. And that's okay. They're institutions. And so in that sense, their focus, we created them as human beings because we needed an operating system that addressed needs in ways that community couldn't. We created the operating system of community because we suffer. As Samuel Beckett, an Irish playwright, once said, "Earth, there's no cure for that." So some of why and how we suffer as human beings mean that there's no drug or medicine or even institutional intervention. There's only community. So what's really interesting is in that operating system, and I think this is what Marianne Thompson was trying to teach, people come together by choice and by consent. What they create is care, not services, or programs or goods. And largely, it is as good as the citizens, in other words, as the contributions of its members. And those contributions come from gifts and capacities, not deficiencies. It doesn't mean that they're not going to celebrate and, be there when people experience fallibility or vulnerability. Not at all. That's where the care comes in. But ultimately, everybody there is a contributor. And it's really interesting. When sickness is the focus, the doctor is the key actor. But when well-being is the focus, community is the key actor. An example of what I'm talking about, there's many, but an example of what I'm talking about comes from Leeds. One of many, I think Edmonton could equally be cited here, but I wanted to give you something with an international flavor. So what I like about the story of Leeds of 7 years ago, when I had the privilege of working alongside them, they really wanted to reimagine how they understood social care and health, but particularly social care. And I suppose there was a recognition that they weren't really using the neighborhood as a unit of change. They were very much thinking about people at the very end of life or, in points of crisis as individuals. An example of what I'm talking about here in concrete, financial terms was, I think this is true to even today. In Leeds, on average, you're going to spend about £46,000 putting somebody in a congregate care setting if you're a social care commissioner. Need your support. £46,000. Now, just to give context to that in terms of what they've been doing over the last 7 years, they've begun to shift the narrative as a commissioning body, the municipality. And instead of just putting the money into buying congregate care settings, they're asking the question, what might we do if we started thinking about the neighborhood as the patient? And they recognize for much less, in fact, they could employ a community builder that could actually enable the gifts of, on average, 10 people per neighborhood who would otherwise be in congregate care settings to be celebrated and recognized in community. In other words, instead of defining somebody out of community and into service land, they're redefining people who are at risk of not having their gifts received back into community. Not just as service providers, but as community precipitants. There's a new function for the 21st century health worker, that we are precipitants of citizenship and of community, not just providers of stock health services. I'm going to run out of time, so let me try to say a few words in closing. I think in essence, the operating system that we're talking about is a system of associational life. It's the clubs, it's the groups, it's the associational networks. And largely, we don't see them. They're not on our radar. They're not on our map. So one of the calls to action today that I'd like to extend to you is, please, let's get serious about lifting up and cheering on the associational life of our neighborhoods. If we don't know what that associational life is, let's put some resource into enabling the community to map out those associations. So let's shift from maps of misery to maps of associationality. The second call to action as I come to conclude today, and maybe collude with the troublemakers in the room as well, is let's recognize that in every community there are 6 building blocks which are absolutely essential to health. There's the gifts, skills, talents, knowledge, and experience of people in those communities, particularly people who've been labeled and pushed to the edge. There's the associations, which I've talked about, but also the local institutions, the mama and papa stores, the local library, if you're lucky still to have one left, the post office, again, if you're lucky to still. Those local institutions do so much in terms of health creation. It's incredible. But also there's the place, the built and natural environment. We also must remember that in all kinds of ways, not just in economy, but in all kinds of ways, that our communities are in exchange relationship with each other, whether it's exchange of sugar or favors or money. Imagine living in a neighborhood where every dollar cycled 3 times more in that neighborhood. How much better would that be for people's health? Imagine living in a neighborhood where people figured out that they could have a fleet of electric vehicles that they could share as a neighborhood, taking the economic burden off of families when it comes to transport. Imagine. Well, it's already happening, actually, because the stories, the culture, the heritage of doing things ground up from inside out is actually catching on. The genie, albeit slowly, is emerging out of the bottle. And what we're seeing all over the world, and I would invite everybody here to celebrate and lift up and shout loudly and proudly about, is that communities have functions. They are enabling of health, of safety. They steward our ecology. They look after our food, care for our economies, look after not just young people, but right across the life cycle. And they are the great producers of care. The engine room of health is not in the hospital. It's in hospitable communities. And so as I conclude, what I'd like to suggest is this is not a zero-sum game. This is not an either-or. It's not about either institutions or communities. But it's about being in right relationship with each. And I think a way of thinking about that is to imagine like a 3-lane swimming pool as you think about the future of your province. In the first lane of that swimming pool will be things that people will do to create health on their own with their neighbors. Our job is to remove the barriers and cheer them on. In the second lane, there will be things that communities will do, but with a little help from us. Our job is to be humble, to be on tap, not on top. And in the third lane, there will be things that our communities need us to do for them, where our expertise, our complex understanding of systems, our institutions will come into their own. But we cannot know what to do in the third space until we start to really lift up, invest, resource, and cheer on the first 2 spaces. So I thank you for everything you do. I wish you well in everything you continue to do. And I say to you, stay in trouble. Thank you.